Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Diagnostic cast of the partially edentulous patient may pose a special problem when trying to mount them on the articulator. When you approximate the cast in the centric occlusion position, they may have a tendency to rock, and it will be difficult to find the correct position. Now, this may also be a problem when mounting in centric relation at an increased vertical dimension with a wax bite also, because the cast or the wax bite will not be supported in the partially edentulous area. Now, as you lose more teeth in the arch, either this way or coming this way, and the remaining teeth begin to approximate a straight line, the more the tendency for rocking will occur. So the larger the base area of the dentition, of the opposing dentition, the larger the base area of those occlusal contacts, the more stable the occlusion would be. If there were a molar in this position, then we would have no problem at all, because that base area would be rather large. But you can see as we lose the teeth, this base area becomes smaller, and the more the tendency for rocking. So to alleviate that this situation, we must construct a jaw relation record base. And this record base will help support the occlusion in the partially or in the edentulous area, particularly this area. Now, you can see that we can put a wax stop there, and when we take our bite relation from the mouth, the cast will be supported in this posterior area, and the tendency to rock will be eliminated. Looking at the record base, there are certain criteria for it. As you can see, it rests on soft tissue mainly, or totally on soft tissue, except for the anterior area where I have it resting on the lingual surfaces of the mandibular anterior teeth. But other than that, it's resting on the edentulous ridges. Now, these can be made for Class 1 patients, edentulous patients, partially edentulous patients. They can be used in the maxillary arch also. And this is a mandibular Class 2 situation where we have the partially edentulous area on the one side. That is the area we're going to replace. Now, it should be of a rigid material so that it should fit accurately the cast, and it should be rigid so that when it is manipulated, when you place wax on it, it isn't going to distort easily. It should also be in the mouth very stable, and we will check the stability of that in the mouth before we would take the record base. Now, in the fabrication, the first thing that we would do would be to block out any undercuts on the cast with a pink baseplate wax. This is the denture or baseplate wax. Now, this wax cleans up very nicely from the cast and leaves very little residue when it is cleaned off properly. We would add it with a spatula, and we would block out any undercuts on the cast, particularly around the cervicals of the teeth, any areas of the ridge which would happen to be undercut, particularly in the very posterior, just lingual and inferior to the retromolar pad in the lateral throat form area, and possibly just under the terminal abutment tooth on the free end saddle side. Those are specific areas that you can look for, but obviously every mouth will be different. And so these areas on the lingual, of the teeth should be blocked out with the wax, because we're going to place a hard acrylic, or we're going to place the acrylic while it's soft, and it will have to set up on this cast or will cure directly to the cast, and we want to be able to get this acrylic off without fracturing the teeth. Now, we would also like to have clasps on the jaw relation record base to help hold it in position, in the correct position. So we would bend clasps which would loosely fit the lingual area, but would touch the buccal surface. See the buccal surface, it is engaging an undercut area here, but the accuracy of the adaptation, particularly in the lingual area, does not have to be good, because we want acrylic to go under it to hold the clasp in position. Now, the clasp is made of orthodontic wire, stainless steel wire. Anything such as an 024 or even anything slightly larger than that will suffice. It'll be just a little bit more difficult to bend. Paper clips will do if you have nothing else handy. But we would do this with the pliers that we characteristically use in partial denture. The 118 plier or the 200 plier, which is commonly called a three-pronged plier. You see the three prongs on the end of it, used for making curves in wire. Just to show you how you would start the bending of the wire, I'll just make a brief start on bending a clasp. You can see you can bend a curvature in the wire with the 118 as well as this 200. You can see that this, just by bending, will also bend a curvature. I'm not going to bend that total wire, but you can see that I have made one for the bicuspid area. One should be made also for the molar area. Engaging the undercut here, and if I turn this around, we can see that it has a retentive area. It will have a retentive area in the acrylic also. The retentive areas should be bent in at least 2 planes to ensure that when the wire is flexed, that it will not just rotate out of the plastic or can be pulled out of the plastic. So it should have a bend in at least 2 planes and not be just a straight wire stuck into the acrylic. So this wire, one of the criteria for the retention of that wire in the acrylic is that it is bent into 2 planes. Also, something else that we might have to bend would be a reinforcement wire, particularly in the lingual bar area. We do not want the jaw relation record base to flex in the center or in the lingual. It should be rigid across the arch. If I apply pressure, such as I'm doing here, it should be fairly rigid. So this means that there would have to be a bulk, either a bulk of acrylic in here or a reinforcement wire made from something like a coat hanger material. And that would be placed into the acrylic in this fashion. Could be placed up higher. Now, if there is a large space between the teeth and the floor of the mouth, the less need there is for this reinforcement, because that means the more acrylic there would be. Now, if the patient has a particularly high frenum attachment, say somewhere in this area, you would see that that would leave a very, very narrow area of acrylic. And so we would like to reinforce such a situation with the reinforcement wire. Now, in the mandibular arch, the acrylic can be brought up over the cingulum surfaces of the teeth and still will not, and it will still not interfere with the occlusion of the teeth. Now, in the maxillary arch, this is not true. The maxillary arch, because you have occlusal stops on the cingulums of the maxillary teeth, in this area, you would see that if you were making a jaw relation record base on a maxillary cast, you could not come up over this area without interfering with the occlusion. But you may do so on the mandibular cast. So when we have all the wires bent for this patient, we would have to, number one, lubricate the cast with a tin foil substitute or by placing tin foil. Now, we would choose to do this with the Alcoat material. Now, this is just placed on with a brush. I'm going to put it on this other cast. It should be really placed on quite liberally. And before you sticky wax the clasps into position from the buckle, over the entire area that you will be adding the acrylic to. Okay, now that can be drying from on the lingual side, and we would then place our wires in position. Now, the wires would be placed in position and tacked with a drop of sticky wax from the buccal surface. If we placed it on the lingual, we would interfere with our retention into the acrylic, since that's where we're going to place the softened acrylic. So we tack them from the buccal surfaces and hold them in position. Okay. Now, the acrylic, when the liquid foil has set, the acrylic that we will use in this case is the Cur Format material. Now, this has a lot of filler material in it, and it is not the most accurate of all the acrylics, but it will suffice if we're not going to store the jaw relation record base for a long period of time, if we use it rather quickly. Now, all we do, this is pre-measured. Is to add the liquid to the powder and mix it till all the liquid is incorporated. Now, we'll just set this aside for a very brief minute while it loses its excess monomer before it's easy to handle. The acrylic that we could also use is the perm acrylic or any auto-polymerizing repair acrylic. This will also work for the fabrication of a jaw relation record base. It is it is more accurate than the material that we're using, slightly more costly, but any auto-polymerizing acrylic can be used. the perm and some of the other acrylics are probably best used if they are sprinkled on, if you sprinkle the powder on and then wet it with the monomer. Now we'll look at the acrylic, the Formatray material that we are going to use now. And it's starting to lose its gloss. I have lubricated my fingers with Vaseline. And we see that it's now ready to take out and use in the doughy state. I would prefer to make this into a roll and then start to adapt it to the cast. Now, it should be of sufficient thickness that we're not questioning the rigidity, but it doesn't have to be so thick that it's going to interfere with occlusion and etc. So as I press this, I'm having the finished thickness in mind, which is probably 1.5 millimeters to 2 millimeters, and in the lingual bar area we will want it thicker than that. Remember, I said that if we had to, we would add a wire for the rigidity. Now that could be done either now or later. Now what I do is to, while it is still soft, I begin to trim it. Now make sure that those wires now, we press on the lingual areas where those wires are so that they are going to be incorporated and wrap around the wire, the bend in the two planes, and so there will be no problem of retention of the wire. Now I would continue to trim this acrylic both from the lingual and from the buccal, such as this. Remove it and then let the material sit. And as the material is polymerizing, I would continually try to keep it adapted, or else you will get some sort of bounce from the material as it shrinks during its contraction. Okay, now I would just continue to trim and let this set. We see here the finished jaw relation record base. Now the finishing sequence for the acrylic in the rough state would be to use these following instruments. You could use the arbor band to trim the excess acrylic, and for a little finer finishing we can use a fast cut stone or an acrylic burr or both, and then to take the burr off of the wire clasp so it's not injurious to the patient, we would probably use either this sandpaper disc or maybe a burlue wheel would work. But these are the instruments that we use to get it to this point. Following the use of the fast cut stones and the peripheries, we would also take it to a pumice finish. There's no need to go beyond the pumice finish and into a Bendix finish at all. Here we have, again, the finished product, and I'd like to describe it to you, the peripheries to you, so that you understand its function. It should be stable to pressure in the base in the pad area. It should be covering the edentulous ridge, the stable part of the edentulous ridge. It should not be overextended at all. In fact, if anything, it should be underextended. We see this lingual periphery should be up short of the soft tissue attachment of the patient. This would be double checked in the mouth at the time of insertion or placement in the mouth. The lingual bar area here will be short of the attachment so that the tongue movements do not displace this appliance. Again, on this side, the short of the lingual turn and short of the attachment of the tongue. On the buccal, it should be also short. Now, these attachments will be double checked in the mouth, but when you're fabricating them, we know that the alginate impression has a tendency to overextend the soft tissue landmarks because of its consistency. It pushes them out of the way. So in fabricating the appliance, we would cut that short of the alginate, or the peripheral turn here that we had from the alginate. The clasp is in contact with the retentive area of the tooth in the infrabulge area. The clasp is also incorporated into the acrylic. The lingual bar area, again, from the standpoint of rigidity, should be very rigid. We can either leave the acrylic thick, if necessary, add the reinforcement. Now here we see to enhance our cross-arch stability of the appliance, we have come up higher on the cingulum teeth and the cingulums of the mandibular anterior teeth, knowing that we can do this without interfering with the occlusion. In the maxillary case, this would not be true. Now I'm going to take this off and we'll look at the surface, the undersurface of it. The undersurface should not have any bubbles or projections which are going to injure the patient or make it uncomfortable for the patient. The peripheries are polished, so they will not be bothersome to the patient. The wire is incorporated into the acrylic so that it cannot be twisted or displaced. Look at the wire on the opposite side. The retentive area of this wire should be well into the wire. If you have a slight burn through, such as we have in this area, that is of no consequence whatsoever, because the majority of that wire is embedded. And we see the undersurface of this side is also smooth and will not bother the patient. If there is any portion of the record base which is causing pain to the patient, that alone may cause a deviation of the mandible, or if you're using some impression material or a material such as wax to record the bite with, they may deviate to one side or the other to favor the side that's being injured. So we want to be sure that this appliance is not causing or inflicting any pain on the patient. Now, this would support a wax occlusal rim in the actual bite or the actual jaw relation sequence on the patient. It will support a wax rim in this area. So the jaw relation record base supports a wax occlusion rim, and the wax occlusion rim is actually the substitute for the missing teeth. Now, it is not necessary in the fabrication of that to put the wax rim along the whole surface, but it should be done at the time of the delivery to the patient so we can see what the opposing occlusion is and how far down the opposing occlusion will come. As we can see here, this molar tooth, this maxillary molar tooth, will probably be interfering with that record base, and so at the time of delivery to the patient, we will have to trim this. It should in no way interfere, the jaw relation record base with the wax occlusion rim should in no way interfere with the occlusion.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.